Thank you for coming. This is the second part of a series of workshops on research on evidence-based practice. So before we can, so last Friday we talked about the conceptual framework of evidence-based practice, and today we're going to talk about how to translate this framework into research on evidence into practice. So translated means applying or implementing research evidence to practice. Okay, so just a recap of what we talked about last time. Last time we talked about a number of models to guide us to decide what's best to practice based on evidence. There's a very simplified model called the 5-step evidence-based process that most of us are aware. If you search the term evidence-based practice, this 5-step will come up automatically. So basically it includes the ask, formulating a clinical question, assess, track down the best evidence, and evaluating, appraise the evidence for its validity and usefulness, and apply whatever we find the results into a clinical practice, taking into consideration the unique characteristics of the client and the culture of the place that we work in. And then the final stage is to evaluate the effectiveness of the entire process, as well as the intervention that we put together based on evidence. Now, last Friday, we also looked into a very useful model called the Hawkins Model. This model is borrowed from the medical field, particularly in department of nursing. In essence, they're dealing with clinical questions, asking how to conduct intervention with clinical samples, individuals with medical and health problems. So it's very elaborate and it's very popular in the area of medicine and nursing and the healthcare discipline. So it also, it has very elaborate stages, but to put it in a diagram, okay, this is I don't need this pointer now. Okay, it includes an inquiry stage, and then a practice learning phase, which includes using a practice question to find the evidence and to translate or apply or implement it into a practice, to decide on the best practices, and then to hopefully at the end we are improving our practice. So basically today what we are doing today is to go through the evidence-based practice process, mapping the 5-step into this Hawkins model. This Hawkins model is very useful because it guides you step by step how to decide on what intervention you are going to do. Now, there's another term we call evidence-based research, okay? And there's also another term, research on evidence-based practice. So today, the Hawkins model primarily is working on how to devise a best evidence-based practice, okay, the intervention. But we can also elaborate this model to do a research on this evidence-based practice, whether it's indeed deliver its intended purpose. Now, on the other hand, we can also use this model to conduct our research, which is called the evidence-based research. So research, just like Washington, the one that discovered the apple falling down from the apple tree and discover the law of gravity. Okay, that's how different people ask questions, and then come up with the answer, and then generalize to other phenomena. But evidence-based research is that we ask a question based on the evidence available to us. So even though the terms are different, but the process basically you can elaborate or based on all this process. So let's try to map the 5-step process model into this Hawkins model of evidence-based practice. Now, the first step of the five step is the ask. Okay, so how do we ask a evidence-based question? Okay, or a clinical question that is eventually evidence-based. All right. So start with, we are doing the practice question, and then we search for evidence, best way to find a way to answer the question or derive an intervention and to implement the intervention. The ask step include identify an evidence-based practice question. The second step is to define the scope of the practice question. Let's just go through it, and this will be examples in the following slide. And the third step is assign responsibility for leadership. So it basically requires a team to do evidence-based practice, all right? And recruit an interdisciplinary team. And step 5, schedule a team conference. So that's the first step that is included in asking an evidence-based question, okay? Next, so this is elaborate, how to ask a question. Before we ask a question, we need to do a Pickle Search. This includes ask and assess stage of the 5-step process model. It includes formulate the Pickle question. PICO is a short form, which later on we also go into detail. Identify keywords for each element, plan the search strategy, identify the database, execute the search, refine the results, review the literature, and assess the evidence. That's what we always do, okay? Actually, one of the hallmark of evidence-based practice is to document what we have done, the documentation, clear documentation so that people can evaluate and can repeat and replicate. So a lot of people said, there's nothing new, I always did it. But did you document it clearly and concisely so that people can follow through, evaluate what you're doing, and then replicate what you're doing? So let's go through a little bit detail. Ask clinical question. We said use Pickle. What is Pickle? P stands for the patient, the population question. What are the most important characteristics of the patient if we apply into a medical or social setting? Okay, if we apply to a client in our field in clinical or counseling, what is the characteristic of the client that you're going to, derive an intervention, or what is the characteristic of patient that you try to intervene? Okay, and then I stand for the type of intervention. What major intervention are you considering? Okay, and C represent the comparison. Other than the one that you had in mind, what other options that you need to compare so that your effect of your intended intervention will be compared with another intervention. See whether there's incremental effectiveness, if it's equally effective, okay? Outcome, O stands for the outcome, okay? What is the estimated likelihood of a clinical outcome attributable to a specific disease, right? So let's give an example, okay? A 27-year-old woman with mild PTSD symptoms after a road traffic accident. So this person come to us. We want to derive an evidence-based practice to help this person. So before we do anything, we have to separate background information and foreground information. Background information refer to broader general information about the type of problem, the type of patient or the client that we have. And these are all available in the textbook. How frequent PTSD occur after a road traffic accident? Do you know how frequent it is? About 30%. 20 to 30, mild, we're talking about mild, okay? About 20 to 30%, which is quite consistent across different regions. What is typical presentation of PTSD symptoms? Most of us know. Hyperarousal, what was that? Nightmare and hyperarousal, what's that? Dissociation and all those. So these are those. So we have, if we don't know, we can look for in textbook. Okay. And what is the clinical cause and complication of PTSD? So what's the complication if it's not treated properly? Then it will develop into chronic, and then it will intervene with the person's functioning in most aspects. And then there are also other comorbid conditions like drug abuse and things like that. Now these are the background information that is probably happen to most of the clients that have similar experience. But there's the foreground information is specific to your client at this moment. Okay, this 27-year-old woman with mild PTSD symptoms. How effective is CBT for PTSD? The textbook will tell us CBT is a treatment. So we will be asking how effective CBT is for a 27-year-old woman for mild PTSD. How does it compare to drug treatment? Because mild symptoms typically is insomnia, cannot sleep. Okay, so how about just taking sedative, sleeping pills, or other drug treatments? What are the contraindications for using CBT in reducing? Even though a lot of people want CBT is the choice of treatment for PTSD, but there are pages and pages of contraindication. That means people with this presentation, you cannot give CBT. Okay, so we have to search for this. We have to understand this foreground information. Now, start to ask the question. We said asking the clinical question, ask whatever question you want to ask with the pickle. P is the population. A 27-year-old woman reported PTSD symptoms after a road traffic incident. This is the characteristic of the client that you are going to deal with. The intervention, you decided, because with the foreground information, you know that trauma-focused CBT is the best, okay? Comparison, and some people use drug together with CBT or drug alone, okay? So this is your comparison group. Outcome, what do you want to achieve? Reducing the PTSD symptom, okay? This is the type of question that you need to ask, okay? Then another example, okay? The pickle process, for example, this is for public health, okay? And this program is interdisciplinary, involve public health, social work, psychology, counselor, PT, and OT. Okay, so I have an interdisciplinary team, and we want to, because for elderly individuals, one of the big problems is fall, accident. Because for older people, falling is very risky because they have broken hips and things like that. So fall prevention becomes a very major public health problem, and it's better to prevent than do something after the elderly person fell down. So the population, you have to decide. Older people, there's still so many types, okay? Young old, middle old, old people with certain conditions. So we decided to find this after the meeting, or since this is interdisciplinary, clinical questions that people want to address. So consensus decide senior over 65, okay? This is the population that we want to characteristic. And it's a community elderly people, not those who are in the residential home. And those have a history of falls. They have, mild falls before. They have fell down before, okay? So these are the population characteristics that we want to derive at EBP. Okay, and the intervention, what do we do? There are so many types, and the group decided traditional rehabilitation plus multifactorial fall prevention program. There's a program that's well established, so they decided to use this one, compared to traditional rehabilitation program, okay? And outcome, decrease incidence of falls and avoid hospitalization. Okay, so these are the questions, these are the outcomes that we had in mind. Not yet to derive an intervention yet. This is to ask the question, these are the framework. The next step, okay, assess and appraise the evidence. Okay, so the second step in all this procedure, mapping into the Hawkins Model, the practice question we address with the pickle, then it's evidence. Evidence, we go through the step first, okay? And you probably will be, some of, that's what we do, okay? We have patient group, we want an outcome that we want to do, and we have in mind something in our mind, okay? So and you do not know and decide which one is the best one, okay? Which one to choose, okay? So this is the stage where it helps us to decide, to formalize the intervention program, is to search for evidence, conduct an internal and external search of evidence, appraise the types of evidence, we go to detail, okay, and summarize the evidence, rate the strength of the evidence, and develop recommendations for change in the existing intervention or use an intervention that with the best evidence, okay, or based on evidence, you modify an existing program. Okay, that's the purpose. So it's a very important step in the evidence-based practice. Now, we said search for internal, external. Okay, information, nowadays, no problem in finding information. Okay, there's two types of information, Google and research database. Okay, so I won't go through it, one of them. So when you're doing evidence-based practice, the evidence should be coming from research database, because as you see, Google, everyone can put up something, and they can, you can pay to be show up in Google also. Plus, when you type a keyword, there's so many things coming up to Google. When you go to the link, sometimes the X-rated things coming up. So a lot. So and in particular, the data is no validation. Okay. So if you're doing evidence-based practice, your search database should be coming from the research database, which these are more reliable as they tend to be peer-reviewed, particularly journal papers or conference presentations. Okay. So this. And there are useful databases for different disciplines. For social science, for medicine, sometimes they overlap, and depends on if you're social science, getting with some medical conditions, like if you're in health psychology or clinical psychology, your database will be overlapped with medicine. Now, one thing is that some of the database is not that you want to assess. That's one of the complaints about frontline colleagues that they are not affiliated with any big hospitals or big institutions. They are small group or NGOs. They don't have access to all these good research databases. They are very expensive to buy. Okay, so typically this evidence-based practice team will have someone in the academia or affiliated with large hospitals. Major large hospital clusters tend to have their own medical library. And they tend to have Medline, PubMed, and Cochrane's library, things like that. So when you pair up in a team, one of you will have access to all this. Okay, so now how do we evaluate the evidence? There's so many evidence, so many different research findings. There are different ways of evaluating, appraise, that means assess and evaluate your evidence. Not all evidence are equally reliable and consistent. So this is a pyramid. Those who are down there will be less. It depends on how what is the criteria for piling them together. Okay, so this is the 5 S of evidence in Haynes 2006. The is level of evidence to start with is probably individual studies. And then so individual study, no matter how vigorous you conduct your study, there's still some limitation. So if you have a cluster, if you look at integrated results of more than one or a group of studies, so the results will be more, you will be more confident than just one studies. And then there are also some good signal. Sometimes we just look at the abstracts, okay? Some database could, provide you with lots of, good abstracts so that you don't need to go into individual studies. Okay, and summaries in textbook, practice guidelines. Later on we talk about the best practice guidelines, okay? And the systems and the electronic health records, okay? Electronic health records of your, in the medical field is the most evident, okay? Those who are in the medical record, usually, they are the record there, okay? So history of any comorbid disorder, how long they take the drug and the symptoms. So medical history is considered one of the very reliable evidence. Again, that is not easily available, okay? So just like if you're working in a social service setting, the file, okay, will be the most, reliable, okay? And then another way of looking, evaluating or appraise your evidence is the reliability. Now, you go down, those down there are observations down in the pyramid are less reliable. As you go up the pyramid, it's more reliable. Observational study, that means based on observation, interview, they are less reliable because it's subject to observer bias. And also those who are observed by you will be behaved in a slightly different way, okay? So most people will consider case study or qualitative interviews as the observational study as less reliable than those under randomized controlled trial, okay? And more reliable is your meta-analysis. You integrate all randomized controlled trial. And there's a new form of meta-analysis called IPD, okay? Meta-analysis is based on individual research studies. IPD is based on individual participant data. So it's considered as more reliable, okay? So, so you can see that that's one way to arrange your reliability of evidence. So when you search the database, when you see, usually the first word I ask, meta-analysis, okay? And then individual studies, okay? From the meta-analysis, they tell you what are the studies they consider, okay? But just searching for meta-analysis is not enough because meta-analysis is analysis of study that's been published. So it's an older form. You need to also search for some latest individual study. Okay, so to make your evidence more up to date. Now, in different disciplines, they are slightly, different in terms of how to look at the evidence. So we will not go particularly into great detail, but still you can see that observation, case report, interviews tend to be considered as less reliable in almost all disciplines. Okay, intervention study with randomized good controlled trial and meta-analysis is typically considered as more reliable and more consistent. So this is the way medicine organizes the evidence. This is the way the social work organizes the evidence. Okay, it's the same. Qualitative studies, surveys, pre-experimental group studies, and then cohort study, quasi-experimental study, randomized controlled trial, and system review and meta-analysis. So there's no difference. Basically, you can see that. Okay. So level evidence in psychology. Okay. So again, it's pretty much the same as the other discipline. Okay. Particularly psychology nowadays more and more focus on quantitative type of evidence. Based on a large number of people, then you have some results, and then now we look at evidence. One way we evaluate them is how consistent, how reliable the results are. Another way is what is the evidence of causality? So the study, what type of study make us feel better that this is antecedent consequences, okay? Although everyone said the effect of this on that, but when you look at that, some of them are just cross-sectional, data. There's not effect at all, okay? So the level, what the causality bias is less as we go up the pyramid. So the way you report is different. As you are more confident, that with the causality, because the randomized control trial, you balance everything, you control a lot of things. Well, if you are not familiar with randomized control trial, the pamphlet that's distributed to you have a very good explanation. An example was what randomized control trial. You can conclude it's shown that A causes B. Okay? If it's not randomized, it's controlled longitudinal studies, it's likely that A causes B. Okay? Uncontrolled longitudinal study, there are signs that A may cause B. Okay? Cross-sectional study and case studies, A is related to B. You see how the terms differs? Expert opinions. Experts are of the view, of the opinion that A may cause B, or A is related to B. Okay, that's how, based on the evidence. Okay, so for example, in the process of collecting evidence as to whether CPT is effective in reducing PTSD symptoms, if you just interview a very experienced clinical psychologist, you can report that based on the evidence, experienced experts in this field, they are of the view that CPT can reduce PTSD symptoms. Okay, so this is how we, based on the evidence that's research, then we come up with this type of statement about about relationship between the questions, the intervention, and the outcome. Now, these are the terms that people be always confusing. EVT, EST, and EBT is chronological order. Okay, in the way back, it's called empirically validated treatment or intervention or research. Okay, so basically, wherever I talk about treatment intervention, you can substitute the term research. Okay, so there are empirical validated research or empirical validated treatment. It's first talked about way back half a century ago. Okay, then slowly they talk about empirical supported treatment. Then everybody now says evidence-based practice, and the latest term is evidence-informed. Okay, so these are the terminology. They are different. Okay, empirical validated or empirically supported treatment are pretty much, referring similar things. These refer to specific treatment for specific population disorder that have been proven effective in control research. So empirically, we note, based on RCT studies, we found that individuals with panic disorder can be, treated with CPT are effective in terms of reducing their panic symptoms. Okay, so based on empirical validated study conducted by randomized controlled trial, we found that individuals with panic disorder emotion-focused therapy, interpersonal therapy, CPT therapy are all empirically supported or validated treatment. Now, empirically validated supported treatment form the basis of our EPP when we choose what type of intervention to start with. These are the ones that we pick up. Okay, so we don't just pick any intervention. Based on evidence, the evidence mostly will be empirically validated studies. These are the evidence. The evidence typically consists of empirically validated or supported treatment. These are necessary but not sufficient requirement for evidence-based practice. What is missing? One very important part of evidence-based practice is we have to take into, in last seminar, we talked about evidence-based practice is that we have, based on empirical validated supported treatment or evidence-based treatment, we have to still take into consideration of the unique characteristic of the client that's coming to see us. That's the group of clients that we are handling now or manage. We were helping them now. And the culture, the particular culture or religious group or religious or community that they are. So therapist is guided by the approach with client by current and relevant research on effective treatment for particular problem. And typically these are empirical supported treatments. Okay? With this empirical supported treatment, then we have also to consider the unique characteristic of client and the culture to make modification to this empirically supported treatment that's been found useful, effective for other populations or other clients, similar clients. Okay, so this is what we call evidence-based practice. It's similar, it's not similar, the same as empirical validated treatment. Okay. Now, so since empirically supported treatment forms the basis of our evidence-based practice, so we also take a look at empirical supported. In a nutshell, these are studies. We need to go out and collect data, be it collect data through interview or focus group or survey or physiological measures, MRI. These are empirically supported versus those we look at, previous history and anecdotal data, okay? So as we go down here, these are the unpublished data, so they are less vigorous. These are the weaker empirical supported treatment. So based on a PhD thesis, these are considered as unpublished data, professional opinion, or prior experience. Now, as a therapist or as a counselor, in the old days, you learn from your mentor or your supervisor what they have been found useful when they were students, when they were taught by the mentor. Okay, so but nowadays these are considered as very weak empirically supported treatment. Okay, so the next level is expert consensus based on formal procedures. Primary research study collecting having limited internal, external, and then as you go on, of course, if your studies, the way you collected your data is through a randomized controlled trial. So it's a very strong empirically supported treatment. So all this evidence form the basis of treatment decision making. And then we deliver, with some modification, deliver the psychological treatment and treatment monitoring and outcome evaluation. Okay, so these are delivering psychological treatment based on empirical supported treatment. Now, one word about counseling and psychological intervention. We all talk about common factors. And that's a word of caution. The client this portion accounted for 87% of the variance in the outcome. So if the client, 80%, if the client recover, 80% of the recovery is accounted for by client or extra therapy factors. Okay, the rest, okay, the remaining is accounted for the client-therapist relationship, the model, the technique that you're using, and the feedback they get from the client. Okay, so even bear in mind, even we have a very stringent put together evidence-based practice, it's not 100% accounting for the recovery or the desired outcome. Okay, so this we have to bear in mind. Now all this number does not add up to 100. I don't know why, but but they said, just for example that, with this, the treatment effect and the model technique accounted for only 20% of the 50% of variance. That's not accounted by for the client. Okay, so this is in reality something that we have to bear in mind. It's unlike medical procedures. Okay, it's very clear cut. If I do a surgery, remove the lump, and the pressing on the nerve disappear, then the recovery is, a large percent of the variance is accounted by the evidence-based practice. Now, we have talked about asking the questions, search, assess, or evaluating the evidence. And now we go to the part that most people are excited about, translation, okay? Implementing the intervention, or start doing the research if you are asking for evidence-based research, okay? Translation, there's 11 to 18 steps, okay? Let's go through the steps first, run through it, and then each one will be going into detail. So when you are trying to implement or translate, apply the evidence to your clinical question, this is the time to determine the appropriateness and feasibility of translating your evidence or recommendation into the specific practice setting, okay? And create an action plan. Step 13, implement the change. Step 14, evaluate the outcomes. Step 15, report the results of the preliminary evaluation to decision makers. Step 16, secure support from decision makers to implement the recommended change internally or in a wider scale. Okay, so you start with one center or pilot, then if report the preliminary evaluation and then see if you can implement in a wider scale. Step 17, identify the next step, whether you should stop there or continue. Step 18, communicate the findings. Okay, let's go to each one individually. So this is also something that we have to think about in terms of when we are doing implementation. Other than we have to, so it's not, sometimes it may not be enough to find the best evidence, and then I have a very good intervention plan with all the evidence, with all the intervention modification, but there are still other things we have to consider in applying and translating the evidence into practice. Assess organizational culture and readiness for evidence-based practice. I think some of your frontline colleagues would tell, they don't care about what evidence or what evidence. It just tell me how many clients you see. I just need the statistics, okay? So see how is it, and some if you're in a setting, and in some university setting, you can do nothing except evidence-based practice. Okay, so each organization, each setting is different in terms of their acceptance and readiness for this type of practice. Also, after identify organizational culture and readiness, even if your setting is very welcome, there's still other things you need to consider, which we also talk about in the previous conceptual models. It's a very important thing in terms of deciding how successful we are, how effective our evidence-based practice is, to identify strengths and barriers to evidence-based practice, which also include, do you have mentors? Do you have people know how to do it? Do you have people training other people how to do it? And if all these factors are considered as amenable and favorable, then you can implement your practice design or your intervention. And a very important step is to evaluate what you have implemented. So in a nutshell, you have to consider, after asking questions, after searching the evidence, you have to consider the patient, the values, the preferences, the concerns, the practitioner skills, reflections, are they ready? Okay, the training, and then the organization. Okay, do they have resources? Are they supportive? And then also the profession. How do they view about this? Okay, particularly if you are adding modification to the evidence-based practice. So it's very important for the medical field. Okay, so traditionally, a lot of evidence showing this is the way to cut open your abdomen to take out certain things. Okay, 30 years ago or 20 years ago, people were saying that, oh, you don't need to cut a wire wound. You just need a hole and put a mirror into it. And just a few days, just yesterday, people are doing robots, okay? So you don't need to use your hand. All you do, you sit in front of the keyboard and to, monitor the hands of the robot, the Da Vinci project, okay? So if you modify things to a very well-established evidence intervention, how do your profession feel about it? Okay, so this is also very important. So this is all considered, then you can start your implementation. When you do implementation, there are two approaches. Okay, one is top-down and one is bottom-up. The ideal is top-down. Okay, ideal is ideal. Okay, when we talk ideal, that means something that most of us cannot do. So that means most of us are in a bottom-up model. But ideal is something that we strive towards, and some people out there in the world, particularly in more resourceful places like the Johns Hopkins, the Oxford, the Culture Foundation, okay, they have more resources. They can, they are the leaders of top-down models. What they do is when they implement EBP, they start with controlled trial or clinical intervention, okay? So they have to do all the evidence search, they decide the intervention, they codify the EBP into a package. Nowadays it's called the best practice guideline, okay? So they codify it, they are the one to codify it, and put up on they evaluate whether the way you put together this is, assess whether it's reliable, credible, amenable. They put up in the website for other people to use, and together they packaging it tools, they develop tools. For example, Pickle, there are documents and forms that for us to exercise. Like for last time I said, the way usually we do this EBP training is in the morning we do all this theoretical thing, and in the afternoon we break into groups and do exercise. So each one the problem, we go to the website and search the best guideline for this particular problem, bottom up, okay, this is bottom up. And then from there you also take the tools and scales, because we said evaluation is very important. So how do I measure PTSD? Okay, so these are also people packaged together with tool scales, developing scales, validating scales, etc. So these are people doing all this, packaging them together, and social diffusion. Okay, so they package it together. If you just put in the website, it's not enough. They start training. Okay, they will have training for people to use all these things. Okay, and then they train people to be familiar with all these packages and to provide supervision for local adaptation. Okay, and then to help to evaluate the EBP, and then start the process if any change is that necessary to change the codification, the package they put together. So this is a top-down model. So these are actually not the one they design the think tank, okay? So what they do is, take all the evidence, derive all the steps, okay? Just like the Johns Hopkins model is the top-down approach for us, to do EBP. So we take each step as suggested by them and then follow. So this is a top-down approach. So this is how we do it, how those people do it. Now, we are still using the bottom-up approach, focus on teaching students and practitioners how to use the packages that are developed from best guidelines that develop for use. So the bottom approach are for frontline workers, for the ones who really deliver the intervention, okay? So in terms of taking all this package, we still have the EBP. Search, ask the question, search for the best practice, best skills, best tools, best package for use, and then see if there's any modification. For example, one of the big modifications for us to translate the skill into Chinese, all right? So we have to adopt. And then, for example, if a client, Chinese clients are typically very, they don't fill out long questionnaires. Then we try to develop short forms. These are the modifications. And instead of asking pages and pages of questions, we just select some of the important outcome measures. So these are what we do. Still, we need to do all this and then evaluate how effective it is. So there's different level of EBP implementation. Most of us are doing the bottom up. Okay, when we do bottom up, I'm very quick now, 7:52. When we do the bottom up, this is a slide to show how top-down approach is being put together. Okay, so step one, for example, clinical practice. So clinical evidence-based practice guidelines are typically a top-down approach. Okay, so if you say that I use the practice guideline as my evidence-based intervention, and then I do whatever is suggested by the best practice guideline, this is a bottom-up approach for you. But how do people develop evidence-based practice guidelines? It's a top-down approach. First, identify a clinical area to promote best practice. Okay, later on, I will give you an example. So it's still asking a question. Okay, and establish an interdisciplinary guideline evaluation group. So evaluate, appraise, establish guidelines to appraise the process. Okay, search for and retrieve guidelines. Okay, the guidelines need to be updated very frequently. Okay, so for example, actually this is true. Okay, when I was first in Australia, NUS, Singapore, I teach trauma treatment classes, and then I used the 2011 Australian best practice guideline for trauma-focused psychotherapy. At that time, the list, if you're doing that, the best guideline is the following are the evidence-based practice, CBT, blah, 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 blah. And then they have separate statement that the EMDR is popularly used and has been claimed to be very effective, but there's not sufficient evidence to support it. So use cautiously. Now, if you look at Australia, I did put it up here. If you search for the Australian best guideline for trauma-focused psychotherapy intervention, psychological intervention, EMDR is up there already. Grouped together with the evidence. These following are the evidence-based practice, okay, including CBT and RD, EMDR, etc., etc. Now this best practice guideline has to be updated as people, because how do they develop? People, if you do an intervention based on best practice guideline with some modification, you can submit your report, and then we evaluate, and then put it up on your website and change, and then modify our best practice guideline. Okay, so that's how they keep modifying, and you know how useful they are, not just for practitioners. You know who use this best practice guideline? The insurance company. Okay, so they only pay when the best guideline said this is the treatment of choice. Anything outside of that, they are not paying. And if a professional is sued for malpractice, whatever your practice is within the best guideline procedure, your insurance indemnity will not cover. Okay, so this, and also very important for government funding. The best guideline said the trauma for Australia, not here. The best treatment session is 20 sessions. So they just provide the government, when they said, subsidy, when they do subsidy, they only subsidize for 20 sessions. Beyond that, you either recover or you take money out of your pocket. So these are very important. So it must be evidence-based, okay? So that's how they do, adopt or adjust guidelines for local use, seek external review, finalize guideline, put it up in the website, okay? So this is how the top-down people are working, how they developed evidence-based practice guidelines, okay? So it's a good division of labor, okay? Some resource people, they don't need, they don't need to do this, okay? They just evaluate what other people are doing. So a very good example is a nice practice guideline in the UK. And almost any place, okay? Australia also got one. And almost all profession now, they are talking about best guideline. Business or management also talk about, social worker also talk about everything. And everyone is talking about nice practice guideline. Do you know what NICE stands for? I look at it, I forgot. Okay, national, whatever, okay. So it's a short name, okay. It's not that it's nice and not nice, okay. So it's an acronym for something, which I totally forget about it. So, okay, I give you a preview of the website. You can go, this is the website, huge information, a lot of information. So when you try to do, so you can quickly do an evidence-based practice. Okay, basically, if you find out a nice guideline, so you kind of shorten your journey, okay? So because these people have asked a question for you, have do a lot of, searching and praise the evidence already. And some people had, try out this, this intervention. So this is, people, frontline professionals are more acceptable to say that, okay, I'll practice according to NICE practice guidelines, which is actually they are also kind of practicing evidence-based practice, okay? So I'll give you an example and then we come back. This is the website, okay? You can go, it's open. You can sign wherever, it's just put your name there and then you can log in, okay? So this is the page. We'll go back to it, come back to it. It's a comprehensive and evidence-based, expert input, client and practitioner involvement, independent advisory committee, genuine consultation, regular review, open and transparent process. It's well respected, okay? This NICE guideline office from UK is well respected, right? So let's go to the website. So if you have time, you can just click view all guidelines. There's so many of them, okay? And they grouped you into topics. Okay, so these are the topics. The next page. Okay, see, there's a page, final guidance. So what concerns us most is lifestyle and well-being. Okay, depends what, because if you want elderly, the population groups, okay, these are the keywords you search. Guidelines by months in development, consultations, okay, and these are the things, okay, and also safe stuff. So it's a wealth of information that you can search. So I do some example for you. But you all hear about step care for a lot of mental health condition. Because for a lot of mental health condition, depends on the condition of the person. You don't need immediately go to the emergency room. You don't need to lock up in the psychiatric ward. And also, step care in medical is, very widely used. So for example, if you, they are very vocal now for family physicians. So they are advocating, there's a family doctor seeing you throughout, your family throughout. So you don't need to everything check into an emergency room and with that person knowing nothing about you. And the time is wasted, okay? So the step care, that means that different level of treatment suggested treatment for different level of the condition. Okay, so they have a code for everything. CG90, depression in adults. They have children, so I just take it out. Recognition and management is revised in 2018. Okay, step 1. Okay, so all known and suspected presentations of depression. You you kind of assess which characteristics of your client fit into these subgroups. So if you have a known and suspecting presentation of depression, nature of the intervention is you do assessment, support, psychoeducation, active monitoring, and referral for further assessment and interventions. Okay, that's true for all personnel. Okay, so if you're a teacher, step 1. Okay, if you're at loss, I have a child, seemingly seem to be depressed, I learned something, then what should I do? Then you look at the best practice guideline is evidence-based practice, so you're doing EBP. Step 1, okay, so I do assessment with all that I know, then I ask support of a school social worker, and decide whether, psychoeducation is enough, or we need to further assessment to a clinical psychology or a psychiatrist. So that's step 1. So at this point, no need for drug, no need for hospitalization. Step 2, persistence of threshold depressive symptoms, mild to moderate depression. So mild to moderate, that means in order to consider as a severe depression fulfilling a mental health diagnosis, you need to have the symptoms for 1 month, fulfilling a certain criteria. So this group does not fulfill. So I feel, not eating, not moving, once in maybe once in a week, something like that. But it kind of, interfere with my, so to the extent that I did not go to work, and I did not go to school, and I did not have a good relationship with my child, with my spouse, and things like that. So in this group, you need the evidence told us that the practice is low-intensity psychosocial intervention, psychological intervention, medication referral for further assessment and interventions. This group can be treated as an outpatient or even be treated as a general physician. Okay, you don't need a specialist. Okay, but you need to consider whether to refer to a specialist. Step 3, persistence of threshold depressive symptoms. Then you need medication and the referral. And then step 4, severe, you need medication and other more aggressive kind of intervention. So you follow this suggestion. So it's not that my supervisor told me to do that. Okay, and whatever depressed people coming, the key is to assess them and to refer to the doctor. Okay, even though at the end outcome you still do the same thing, but this is evidence-based, and it's the best guideline has done a lot of background work for you. Okay, so this is the thing. Now another topic for our social worker colleague and some psychology colleague is we are often handling child abuse cases. So NG76 child abuse and neglect 2017 updated. So it's for so many things that you can click. Okay, so you can click what's the best practice guideline for principals working children, young people, parents, and carers. What's the best kind of guidelines that tell us, the factors that increase vulnerability to child abuse and neglect. Okay, so the almost all factors are related. So the best guideline tell us, according to evidence, these are the factors that are consistently shown by research, by evidence, that are related to increased vulnerability. Okay, recognizing how to assess child abuse and neglect, assessing risks and needs in relation. So recommendation, recommendations in session 1 to 3 are for anyone whose work brings them in contact with children, young people, etc. So these 1 to 3 are for general people, general public, okay? And down there are for more professionals, okay? So they have best practice guideline for the general public, for people or general practitioners. So this is very useful website. So in your practice, you might want to make use of it rather than this is what I used to do. Maybe that's at the end you are still doing what you are doing, but you are much confident that it's backed up by the best practice guideline, and you can confidently tell your policymaker this is the way that we should do, to see the client, for 6 or 7 sessions, okay, and this is the way that you teach your students. So it's a bottom-up approach to conduct evidence-based practice. So in a nutshell, most of us are doing it without wearing it, without systematically, confidently tell people we are evidence-based practice, okay? Now, we remember, other than the best practice guideline, we will also have to have some, because a lot of, during the EBP, the loss assessment, okay? So these are also toolkits, a collection of resources, tools, scales, assessment scales, and services to help practitioners to provide evidence-based care to clients. You can go to Johns Hopkins Center for Evidence-Based Practice. They have a lot, they have forms for various, if you're treating PTSD, this is the scale that you can use. If you're doing Pickle, then these are the questions you need to ask. So you just you just type in the Google, the Johns Hopkins Center for Evidence-Based Practice. There's so many resources, okay? But we need modification, at least with the Chinese translation, okay? So you see so many of them. And they recently, I'm not affiliated with them, they recently had the toolkit book, okay? I think they sell not very expensive, the entire book with lots of forms and all the, all these resources that can help us. All these can be found assessing the scientific literature, multidisciplinary practice models. All these can be available in a book. Okay, if you don't want to, just like DSM-5, you can access them through the website, or you can have a handbook carry it in your pocket. Okay, so resources for your patient-centered practice. Okay. So these are the examples. See, they have so many. Pet management care, patient education, translation. Remember the pet, patient education, and translation. Question develop tool, Pickle, stakeholder analysis form. So there's so many things that you can click in. And for specific disorder, like toolkits for modified evidence-based practice to increase cultural competency. Okay, so make use of this. And if you are affiliated with an institution, a school, a university, or a large hospital cluster, this should be available in your library. Okay, and this is almost all practice books are called evidence-based now. Okay, so you have plenty of them. Okay, so this is something. And the other thing I'd like to talk about is treatment manual. It's becoming more and more and more important. Just with all due respect to some religion, we keep saying that this is happening to us just like a second coming of Christ. So with all this treatment manual, they just take the disorder. It's just like the Johns Hopkins model. Step 1, depression, assess, give them, distribute the BDI, depression. Step 2, derive, the pleasurable event inventory, things like that. Step 3, relaxation exercise, imagery. Step 4, so session 1, session 2, end of session 1, homework assignment. Session 2, come back, review the homework assignment. So people are feel very confident. Okay, so this treatment manuals is available for almost, particularly it's popular among CPT. Okay, CPT for cognitive behavioral therapy manual is very, very popular. Why is it so popular? I can finish it before 8:30. Manualization. Move to manualized psychotherapy emerged from its increasing medicalization of psychological intervention. Okay, advantage. Enhance internal validity of comparative outcome studies. So if we want to compare results of different studies, we want to make sure the intervention is comparable. So we want to make sure your CBT is comparable to my CBT. The CBT conducted in agent A, in organization A, is comparable to the CBT that's being conducted by the therapist employed by organization B. Okay, so enhance is internal and external validity of comparable outcome studies, facilitate treatment integrity and therapist technical competency. Treatment integrity, that means a lot of times people will say, I do CBT. Basically, when you really go into what they're doing, actually, they're doing nothing, everything except CBT. Okay, so if you have manual, that you really are doing the cognitive biases, kind of developing alternative, thinking about and challenging their biases, etc., etc. So treatment integrity is that if you claim to do emotional focus or EMDR is easy, you do, but if a lot of us, you have the term supportive head nodding treatment. Okay, when you said you're doing CBT, are you really doing the CBT that we are referring to? Okay, so treatment integrity, doing the type of therapy that you, if with a manual, the chances of deviation from the central focus of that particular treatment method is slightly less than without a manual, right? Ensure the possibility of replication. So wherever I have some modification to this CBT, and then I develop a manual to it, then other people can follow, okay, and then replicate whatever I do. Provide a systematic way of training and supervising therapists in specific model. Okay, so these are all the advantages. There are 4 advantages, there are 5 disadvantages. Emphasize that CBT, treatment manual emphasize that when you develop a manual for CBT, you emphasize the uniqueness of the CBT. But actually, we forgot about the common factor. So right now, at this point of time, there are over thousands and thousands of interventions. Millions, I don't know if that's many treatment manuals. Each one said that's unique, okay? And the focus on the technical operation of the unique aspect of that particular therapy, and totally forget the common factors, and also forget the client needs and client characteristics. My hallmark is my student coming to me so proud that first session I delivered 4 chapters of the manual by David Barlow. But after developing 4 chapters, 25% done with the therapy, because usually it's 6 sessions in Hong Kong. And then so they 25, one session is 20, almost 20% into the therapy. That particular student cannot tell me whether the client is long hair or short hair. What color, if you are a frontline professional, I can say, too many clients. But how many clients students see? Cannot even tell whether it's long hair, short hair, what kind of clothes they wear, skirt or pants. I don't know, because they sit down the table from the table. I cannot see them. That means you sit down and wait till they come and sit down. You didn't, So anyway, so it dehumanizes and show little relate. One interesting thing is that you think you have treatment integrity, people are deviating less from CPT, they're indeed delivering CPT. But that's with some research showing that manual show little relationship to outcome. It's not that you follow the manual, you have better outcome. Okay, so it's little correlation. Okay, high level adherence to specific technical procedure can interfere with the development of working alliance. when you don't even look at your client. It just follows step 1, 2, 3, 4. How can you develop the working alliance? Okay, and some therapists I think at the subtitle, some therapy cannot be scripted. Okay, some manuals are very detailed to the extent of what do you say by verbatim. You said this. Literally, you read up, just like a structured interview or cross-examination. Okay, so, but some therapy cannot be scripted. Okay, CPT in a way can be scripted. That's why it's so popular. Downplay the unique tailoring of any approach to particular client and culture. So you intend to do an evidence-based practice by using a manual, but you ignore a very important aspect of EBP, evidence-based practice, is to modify your intervention according to the client's needs, characteristic, preferences, etc., etc. Okay, so that's the problem of manualization. Okay, with all this, okay, that you consider, then you implement the evidence-based practice. Now, one aspect, okay, is included in the EBP that you have to do evaluation. But a lot of times, when we talk about research on evidence-based practice, is to research on the implementation of the EBP. So, because we said those who deliver it are not the best person to evaluate what you deliver. So, another team member will do the research on evidence-based practice. Okay, but even if you are not doing formal research on your evidence-based practice, you still need to evaluate your practice. Okay, perhaps may not be as elaborate as you embark on a formal research on your practice. So if we're so lucky to be able to do a research on evidence-based practice, now if you don't have resources, if you're the one to deliver it, like I think in 2019 when you come back the second week Friday, I'll talk about a trauma-focused intervention. Okay, I don't intend to do a very elaborate research, but I do want to know whether my client's PTSD symptom improves after my therapy. So all I do, perhaps you can just give a PTS scale to them, or just some statement that asks for feedback. How do you feel about the therapy? Things like that. You still need to evaluate. But if you have the resources to do a formal research on evidence-based practice at this point, then that's what you do. Process evaluation. There are two evaluations for EBP implementation. One is process. Process means how you do as session by session. Okay? So process evaluation is slightly different from outcome evaluation. For some therapy, for some intervention, indeed you need to get worse before you get better. So if you're the outcome, your outcome is not to stress them or make them more anxious, but the process requires to be increase their level of anxiety to the extent that they can tolerate. For example, recall their traumatic memories. Okay, think of some fearful hierarchy. Okay, recall what happened to the traffic accident. Okay, so the process, basically in a nutshell, is how you do the therapy session by session. Okay, if you do a public health education program, is how each time, at each stage what you want to accomplish. Okay, process evaluation and outcome evaluation. So if we are doing a process evaluation, assess quality of the sessions, fidelity, adherence, consistency, and reliability. They all seem to be very similar, but they're slightly different, and there are elaborate scales measuring them. Fidelity, that means how faithful you are using CPT. Okay, adherence, how do you comply to some of the suggestions in your intervention. Consistency, how you deliver the intervention consistently. okay? Sometimes the consistency cannot be maintained because if there's a crisis coming up, you have to deal with the crisis. But withstanding that there's no crisis coming up, how consistent you did, maybe one session you're very energetic, complete 4 chapters of the manual, and the next session without any crisis, you just complete 1 chapter, but you intend to complete another 4. So this is the consistency, the speed, the progress, and the reliability, okay? Is the session that you deliver is reliable, particularly if the intervention is conducted by different therapists or different counselors, or same counselor, same therapist, but you are comparing 2 organizations. So this is something that we have to assess each process, each therapist, and each organization. How is intervention implemented? Sessions, number of sessions, 1.5 hour, group or individual, family, or whatever. So how is the intervention implemented? Activity delivered as intended. Okay, are you able to, successfully persuade your client to do the diary and self-monitoring and derive a fear hierarchy and come back and talk about it? Now, Asians are famous not to do a CBP. One of the hallmarks is homework assignment. It's I don't know about you, maybe nowadays people can do it. No, they don't. There's a whole discussion on some journals talking about, the compliance, because it's the hallmark of CBT, homework assignment, okay? And the first session, each session is to discuss your homework assignment, okay? So activities delivered as intended, participant being reached as intended, okay? If you want to, your intervention is to deliver to family. So your intervention is family therapy. But usually it's the wife who's coming. Or you intend to see the mother and child, usually it's the child. Or usually just the mother, things like that. So our participants being reached as intended. For public education, okay? So your public education, for example, internet addiction, you intend for those who are very, could have very vulnerable to be addicted, but to internet. But those who are coming, they already are very, disciplined and self-monitor already. What are participants' reactions during the process? Okay, so process evaluation typically will ask a lot of those scales for each session. So you can see that this is something that you cannot do feasible if you're individual therapy. It is very resourceful. And also you have to have a group of very well psychologically minded, very cooperative client. Okay, so it's not easy to do that. So a lot of people, good process evaluation is very difficult. So basically, what we usually do is just to see how if we're doing mental health intervention, we see how each session, kind of at the end of the session compare to the previous session, how are they getting and have they improved? Anyway, we have to make sure the client is good, is mentally, good enough to walk out of your therapy room. So you have to assess them. Okay, another group of assessment is outcome evaluation. To what extent a desired change occurring? Now you all understand. To whom? Okay, for couple, for marriage, therapy coming in. Typically, the husband and the wife's expectation is totally different. Okay, I want my wife to be less complaining, less nagging, but our desired goal is that for the wife to be more assertive. So we find out all the problem, the depression, all the problem come up is because the wife, is very, very non-assertive. So to whom your desired outcome is what, okay? Whether it's, is the intervention making a difference, okay? What seems to work and not work? Like most of us, we already know that, do you have problem with asking clients for imagery? Some clients simply cannot imagine, okay? And some of the clients, ask them to do relaxation, that, I'm relaxing. So what seems to work and what not work, okay? So what are the unintended outcomes? This is very important, particularly regarding my examples that a depressed woman coming and with family found out there's a lot of family conflict there, and we all know evidence-based is you teach them assertive training that they're more able to say out what they want and be able to say no. The intended outcome is improve their confidence, improve their self-image, then the depressed symptom might subside. But the intended outcome is that I am no longer a yes person. I'm not your doormat. I want to be independent. I want to file a divorce. I want to start a new life. Okay? So some of these are an intended outcome. I give you an example of a very unintended outcome that work against our wishes. It's true. Many years ago, before I moved to Singapore, I was involved in child sexual abuse prevention for small children up to 5 or 6 years old. So we deliver all these, tell your body parts, these are the private parts that nobody can touch you. If people touch you, no matter who, you can start to say no. And teach them a little bit, give them doors to recognize male parts, female parts. These are parts that other people cannot touch, and you cannot touch other people. We also prevent to be aggressor too. These are the parts you cannot touch. So that's a child abuse case in court, sexual abuse case in court. The accuser was walked free of the trial. The lawyer said, because cases like that, this will be expert witnesses, okay? The argument why this person, accuser, walked free is that we have the argument that assessment, how do we assess these children is draw a picture for them or dolls for them to point out and say something. And there's something that a small child could not be able to tell if they have not gone through the sexual abuse experience. Okay, like very vividly about the male, genital, about how the ejaculation was coming out. So, but the counter argument of the other side is that no, they know all this from your sexual abuse prevention program. I have a name called the Gui Long. For those who are, in our time we know that thing, okay? So this and that. So all our sexual prevention program has to be revamped. So we need to tell them something, but not too vivid, so vivid that it validates all their assessment results. Because our argument, if they had not gone through the abuse experience, they would not have known all this. But the counter-argument is that they just repeat what you tell them from your sexual abuse prevention program. That is not what we intended. Okay? So now we teach all these prevention programs very, very carefully. Okay? So this is what are the unintended. Of course, we all want good outcomes, but sometimes we have also want to see what are the unintended outcomes. So these are the logical, everything has models, okay? Logical models are EBP, intervention, evaluation. So 3 core components of whatever, if ever you're going to evaluate an intervention program, there's always to evaluate input, output, and the outcome. Output is slightly different than the outcome. Input is the program investment. What do we invest? Okay? Concrete things that invested so that the program can be implemented. Example, funding, hiring staff. For example, at those times we are proposing a mobile sexual abuse program that use a truck to drive to different schools, and the children are coming to the truck to have the classroom. So we need to ask Jockey Club to give us money to get the truck, and the truck is not that expensive. Parking and insurance is very expensive, okay, and the wear and tear, okay, and the petroleum, okay, is very expensive. Staffing, we have to train people, we have to do advertising, and space is very important. So these are the input in order, the resources that we need to do, need to have, or need to secure, need to have in place before we start the intervention program. And the output is activities. So you want this intervention. What's the output? It's a classroom, teaching, you deliver the intervention in the classroom. Is do the children get this sexual abuse prevention in the classroom or in an open playground? Or just like the Red Cross, the blood donation in a mobile, things like. So participation, who do we reach under what condition? Actually, it's not fair to do child sexual abuse. All our child sexual abuse program, prevention program is targeting at children. It's not fair, but we cannot reach to the potential. The parents that, they are always in school, okay? Teachers, we are so busy. So we end up, our target is the children. But we all recognize that it's the adult's responsibility to protect the children. It's illogical to ask a small children of 5 to 6 to protect themselves, okay? But it's nobody's business. Nobody is busy enough. It's so busy that they are not attending, okay? Everyone said that we need this program, but the teachers do it, the parents do it. At the end of the day, it's so small kids. So that's the thing. And outcome, okay, is the deliverable. What result can be divided in short term, medium term, and long term. Now, I'll give you an example. Okay, the aim is to evaluate a parent support program to reduce adolescent online gaming addiction. Okay, so it's a support group to reduce. That means it might not be it's support like a public health, prevention program, public education program. So the input is potential eraser question. The input is staff, money, partners, and research. What amount of dollars and time were invested? What did parents do? How many sessions were actually delivered? So this is this is the input, okay. Okay, target parents, okay. Who and how many attendants did you think will come? Did they attend all sessions? Where were they satisfied? Would they come again? Okay, these are the questions you need to ask. How many sessions were actually delivered? So these are the input. You have to develop the parent curriculum, and you can deliver it like a lecture, or you want it to be interactive, or you want also to help them to develop a support group. Okay, these are the things that you can consider. So these are the blue ones are the outcomes. This is the short term, medium term, and probably the long term. Okay, the short term is parent increases knowledge of child development so that they can better understand their own parenting style, which they can also gain skills in effective parenting practices. So the short term, even though it's reducing, the aim is reduce adolescent online gaming, but as a result of public education, the immediate outcome is that they feel they're more confident in terms of, they feel they know that, we want the parents to understand adolescents are very rebellious, gaming is a way of life for the youngsters. They cannot not game or not on the smartphone. And then what are some of the skills in effective monitoring? And the medium goal is the parents, or medium outcome is parents identify appropriate actions to take should their kids engage in excessive online gaming, okay? And parents use effective parenting practices, okay? And long term is improve child-parent relationship, hopefully increase family bonding, and less likely for the child to engage in online gaming. How is it related to online gaming? Because study found out that adolescents, online gamers, addictors, they tend to have poor family relationship, family conflicts, and so they use gaming, addicted to gaming, as various coping strategies to deal with the relationship with the parents or disruptive family relationship, things like that. So it's a public health, okay? So it may not not directly addressing the target problem, but it will hopefully in improving the parents all these long, short, medium outcomes. The adolescents are less likely need to use online gaming addiction as a way of coping. Okay, so this is a logic intervention. So these are the things. Another way, SWOT analysis, business colleagues are very familiar with that. When we put out something, we use a SWOT analysis. Okay, we compare the strengths, the weaknesses, the opportunities, and the threats. Now, for example, if we think about I want to implement a digital mental health program, now it's very, very popular. Okay, digital, some call it I-health, I don't know what they call it, M-health. Okay, I-health is that you can do, they can have, this website, you enroll, if you can check against your signs and symptoms and things like that. If you have any problem, the key into a problem, they have something coming up, and different also step care. Okay, different symptoms, they are different, respond to you differently. The strength for digital mental health problem is immediate support at the point of need, 24 hours a day, 7 days a week. Social equity, which actually is, well, in Hong Kong it's social equity, but in rural, urban countries it's not social equity. Poorer people tend to be less, has less access to digital stuff. They are less competent, okay, and elder people are less competent also. And personalized service tailored to needs, so you can key your own symptoms, okay? And service access to more people, you don't need to go there and line up for the emergency room. Consistency of services. So it doesn't depend, whether the doctor or those who are on call, or nurses, or the car there, or, it doesn't depend on how they handle things, okay? And the weaknesses, the choice is overwhelming, so many things. Just like nowadays, the credit card hotline, press 1, After, and then after hearing that, I totally forget what it is. Then press number, so many, you have, it's just so frustrating. No guidance on efficacy and suitability. So there's not much research, but there is research ongoing to evaluate the effectiveness of digital, mental health program. Lack of empathetic human care. Okay, opportunities, convenience, and anonymity, introduction to care, spreading awareness. Threats, lack of evidence-based effectiveness. Okay, maybe the content of the digital mental health program may be evidence-based, but whether this is the most effective way to do it is that evidence is not coming yet. Okay, acceptance and usability issues, risk of over-reliance on technology, privacy and data security, top-down design, no user, so the user has no participation. Okay, so a program is designed for you. Okay, so that was the SWOT analysis. Okay, the last part, the last but not the least important is you do very well EPP, you do research in that, you need to let other people know. It doesn't need to be a journal. Actually, nowadays, when we have a lot of public money, if you receive public grant, you're supposed to deposit your result and your data in a depository. Because we fund $1 million to you, we don't want us to be accessible to you public a journal, only accessible to those who can read a journal. okay? And only to those parts that you have analyzed and published in a journal or whatever journal. So nowadays, more and more funding agency, particularly public money from the RGC. RGC is not yet going this way, but I think they will soon go this way. Public money, okay? Government money are less open, okay? Some public money, they will ask you to put in the depository, your results, your data for other people to analyze in a different perspective, in a different way. So dissemination or EBP intervention results are very important, particularly very few people dare to say they do EBP intervention. If you do it, you have intervention, you have evaluation, you need to let other people know. These are the channels that you can disseminate your results, presentation, meetings, or even media, okay? Nowadays, people like to disseminate their results through social media, okay? And another thing is also based on your result, you come up with, pamphlets, handbooks, and, books and magazines or whatever, printed materials for people to get access to and for people to take away. So flyers, pamphlets, clinical guidelines, summaries, and for client education, and for audit and feedback, continue to adjust practice, and journal article. I think this is the last slide. So it's not the end yet. So as we said, if we are doing evidence-based practice or doing research on evidence-based practice, usually it's a team of people. And usually it's involved more than one discipline. So the next seminar on next Friday, everybody will be Christmas. On the 8th of January 2019, we'll talk about interdisciplinary research in evidence-based, or even interdisciplinary evidence-based practice. Okay, so we have about 15 minutes for sharing.